Hello everyone, I'm back today with a second audio to read you about the effectiveness of lockdowns. I have here on the website of American Institute for Economic Research, it's kind of a summary of studies that have been made in the last 9 months about how effective lockdowns are. So this was published on their website on December 19th, 2020, so today. So here goes. The headline goes as follows: Lockdowns do not control the coronavirus. The evidence. The use of universal lockdowns in the event of an appearance of new pathogen has no precedent. It has been a science experiment in real time, with most of the human population used as lab rats. The costs are legion. The question is whether lockdowns work to control the virus in a way that is scientifically verifiable. Based on the following studies, the answer is no, and for a variety of reasons. Bad data, no correlations, no causal demonstration, anomalous exceptions, and so on. There is no relationship between lockdowns, or whatever else people want to call them, to mask their true nature, and virus control. Perhaps this is a shocking revelation, given that universal social and economic controls are becoming the new orthodoxy. In a saner world, the burden of proof really should belong to the lockdowners, since it is they who overthrew 100 years of public health wisdom and replaced it with an untested, top-down imposition on freedom and human rights. They never accepted that burden. They took it as axiomatic that a virus could be intimidated and frightened by credentials, edicts, speeches, and masked gendarmes. The pro-lockdown evidence is shockingly thin and based largely on comparing real-world outcomes against dire computer-generated forecasts derived from empirically untested models, and then merely posting that stringencies and non-pharmaceutical interventions account for the difference between the fictionalized versus the real outcome. The anti-lockdown studies, on the other hand, are evidence-based, robust, and thorough, grappling with the data we have, with all its flaws, and looking at the results in light of controls on the population. Much of the following list has been put together by data engineer Eivor Cummings, who has waged a year-long educational effort to upend intellectual support for lockdowns. The American Institute for Economic Research has added its own and the summaries. The upshot is that the virus is going to do as viruses do. Same as always in the history of infectious disease. We have extremely limited control over them, and that which we do have is bound up with time and place. Fear, panic, and coercion are not ideal strategies for managing viruses. Intelligence and medical therapeutics fare much better. These studies are focused only on lockdown and their relationship to virus control. They do not get into the myriad-associated issues that have vexed the world, such as mask mandates, PCR testing issues, death misclassification problem, or any particular issues associated with travel restrictions, restaurant closures, and hundreds of other particulars about which whole libraries will be written in the future. First study, number 1. A country-level analysis measuring the impact of government actions, preparedness, and socioeconomic factors on COVID-19 mortality and related health outcomes, by Rabail Chowdhury, George Dranisteris, sorry if I didn't pronounce that right, Tyler Mubashir, Justin Bartosko, Sheila Riazi, eClinical Medicine 25, published in eClinical Medicine 25, 2020, with a title that goes, Full lockdowns or widespread COVID-19 testing were not associated with reductions in the number of critical cases or overall mortality. Number 2. Was Germany's corona lockdown necessary? By Christoph Kubander, Stefan Humberg, Harald Wallach, Stefan Hockertz, and they advance. On June 23, 2020, official data from Germany's RKI agency suggests strongly that the spread of coronavirus in Germany receded autonomously before any interventions became effective. Several reasons for such an autonomous decline have been suggested. One is that differences in host susceptibility and behavior can result in herd immunity at a relatively low prevalence level, accounting for individual variation in susceptibility or exposure to the coronavirus yields a maximum of 17% to 20% of the population that needs to be infected to reach herd immunity, an estimate that is empirically supported by the cohort of Diamond Princess cruise ship. Another reason is that seasonality may also play an important role in dissipation. Number 3. Estimation of the current development of the SARS-CoV-2 epidemic in Germany by Matthias Anderhayden, Osama Hamouda, Robert Koch Institute, April 22, 2020. In general, however, not all infected people develop symptoms. Not all those who develop symptoms go to a doctor's office. Not all who go to the doctors are tested, and not all who test positive are also recorded in the data collection system. In addition, there is a certain amount of time between all these individual steps, so that no survey system, no matter how good, can make a statement about the current infection process without additional assumptions and calculations. Did COVID-19 infections decline before UK lockdown? By Simon N. Wood, Cornell University preprint, August 8, 2020. A Bayesian inverse problem approach applied to UK data on COVID-19 deaths and the disease duration distribution suggests that infections were in decline before full UK lockdown, March 24, 2020, and that infections in Sweden started to decline only a day or two later. An analysis of UK data using the model of Flaxman 2020 Nature 584 gives the same result under relaxation of its prior assumptions on R. Number 5. Comment on Flaxman and all. The 2020. The illusory effects of non-pharmaceutical interventions on COVID-19 in Europe by Stefan Humberg and Christoph Kobander, June 17, 2020. Advanced Sage preprint. In a recent article, Flaxman and al. alleged that non-pharmaceutical intervention imposed by 11 European countries saved millions of lives. We show that their methods involve circular reasoning. The effects are pure artifacts, which contradict the data. Moreover, we demonstrate that the United Kingdom's lockdowns was both superfluous and ineffective. Professor Ben Israel's analysis of virus transmission, April 16, 2020. Some may claim that the decline in the number of additional patients every day is a result of the tight lockdown imposed by the government and health authorities. Examining the data of different countries around the world casts a heavy question mark on the above statement. It turns out that similar pattern, rapid increase in infections that reaches a peak in the 6th week and declines from the 8th week, is common to all countries in which the disease was discovered. Regardless of their response policies, some impose a severe and immediate lockdown that includes not only social distancing and banning crowding, but also shut out of economy, like Israel. Some ignored the infection and continued almost a normal life, such as Taiwan, Korea, or Sweden. And some initially adopted a lenient policy, but soon reversed to a complete lockdown, such as Italy or the state of New York. Nonetheless, the data shows similar time constants amongst all these countries in regard to the initial rapid growth and the decline of the disease. Number 7. Impact of non-pharmaceutical interventions against COVID-19 in Europe, a quasi-experimental study by Paul Raymond Hunter, Philippe Colin Gonzalez, Julie Susan Brainard, Steve Rushton, from Medrevix, preprint May 1st, 2020. The current epidemic of COVID-19 is unparalleled in recent history, as are the social distancing interventions that have led to significant halt on the economic and social life of so many countries. However, there is very little empirical evidence about which social distancing measures have the most impact. From both sets of modeling, we found that closure of education facilities, prohibiting mass gatherings, and closure of some non-essential businesses were associated with reduced incidence, whereas stay-at-home orders and closure of all non-businesses was not associated with any independent additional impact. Number 8. Full lockdown policies in Western Europe countries have no evident impacts on the COVID-19 epidemic. By Thomas Mueller, Medrevix preprint May 1st, 2020. This phenomenological study assesses the impacts of full lockdown strategies applied in Italy, France, Spain, and United Kingdom on the slowdown of the 2020 COVID-19 outbreak. Comparing the trajectory of the epidemic before and after the lockdown, we find no evidence of any discontinuity in the growth rate, doubling time, and reproduction number trends. Extrapolating pre-lockdown growth rate trends, we provide estimates of the death toll in an absence of any lockdown policies and show that these strategies might not have saved any life in Western Europe. We also showed that neighboring countries applying less restrictive social distancing measures as opposed to police-enforced home containment experience a very similar time evolution of the epidemic. Number 9. Trajectory of COVID-19 epidemic in Europe by Marco Colombo, Joseph Meller, Helen M. Colloon, M. Gabriella, M. Gomez, Paul McKeague in Medrivic's preprint posted September 28, 2020. So a more recent study. The classic susceptible infected recovered model formulated by Kermack and McKendrick assumes that all individuals in the population are equally susceptible to infection. From fitting such a model to the trajectory of mortality from COVID-19 in 11 European countries up to the 4th of May 2020, Flaxman et al. Concluded that major non-pharmaceutical interventions, and lockdowns in particular, have had a large effect on reducing transmission. We showed that relaxing the assumption of homogeneity to allow for individual variation in susceptibility or connectivity gives a model that has better fit to the data and more accurate 14-day forward prediction of mortality. Allowing for heterogeneity reduces the estimate of counterfactual deaths that would have occurred if there had been no interventions from 3.2 million to 262,000, implying that most of the slowing and reversal of COVID-19 mortality is explained by the buildup of herd immunity. The estimate of herd immunity threshold depends on the value specified for the infection fatality ratio, the IFR. A value of 0.3% for the IFR gives 15% for the average herd immunity threshold. Number 10. Effect of school closures on mortality from coronavirus disease 2019. Old and New Predictions by Ken Rice, Ben Wine, Victoria Martin, Graham J. Akeland in the British Medical Journal, September 15, 2020. The findings of this study suggest that prompt interventions were shown to be highly effective at reducing peak demand for intensive care unit beds, but also prolonged the epidemic, in some cases resulting in more deaths long term. This happens because COVID-19 related mortality is highly skewed towards older age groups. In the absence of an effective vaccination program, none of the proposed mitigation strategies in the UK would reduce the predicted total number of deaths below 200,000. Number 11. Modeling social distancing strategies to prevent SARS-CoV-2 spread in Israel. A cost-effectiveness analysis by Amir Shlomai, Ari Leshno, Ella Ashkland, Mosh Leshno in the Medrivic's preprint, September 20, 2020. A nationwide lockdown is expected to save on average 274, median 124, interquartile range 71 to 221. So a nationwide lockdown is expected to save on average 264 lives compared to the testing, tracing, and isolation approach. However, the ICER will be on average 45,156 to prevent one case of death. Conclusions: a national lockdown has a moderate advantage in saving lives with tremendous costs and possible overwhelming economic effects. These findings should assist decision makers in dealing with additional waves of this pandemic. Number 12. Too little of a good thing, a paradox of moderate infection control by Ted Cohen and Mark Lipstitch. Epidemiology, 2008, July 19th. The link between limiting pathogen exposure and improving public health is not always so straightforward. Reducing the risk that each member of a community will be exposed to a pathogen has the attendant effect of increasing the average age at which infections occur. For pathogens that inflict greater morbidity at older ages, interventions that reduce but do not eliminate exposure can paradoxically increase the number of cases of severe disease by shifting the burden of infection toward older individuals. Smart thinking, number 13. Smart thinking, lockdown, and COVID-19 implications for public policy by Morris Altman, Journal of Behavioral Economics for Policy 2020. The response to COVID-19 has been overwhelmingly to lock down much of the world's economies in order to minimize death rates as well as immediate negative effects of COVID-19. I argue that such policy is too often decontextualized as it ignores policy externalities, assumes death rate calculations are appropriately accurate, and, as well, assumes focusing on direct COVID-19 effects to maximize human welfare is appropriate. As a result of this approach, current policy can be misdirected and with highly negative effects on human welfare. Moreover, such policies can inadvertently result in not minimizing death rates, incorporating externalities at all, especially in the long run. Moreover, such policies can inadvertently result in not minimizing death rates at all, especially in the long run. Such misdirected and suboptimal policy is a product of policymakers using inappropriate mental models which are lacking in a number of key areas. The failure to take a more comprehensive macro perspective to address the virus, using bad heuristics or decision-making tools, relatedly not recognizing the differential effects of the virus and adopting herding strategy, follow the leader, when developing policy. Improving the decision-making environment, inclusive of providing more comprehensive governance and improving mental models, could have lockdowns throughout the world, thus yielding much higher levels of human welfare. Number 14. SARS-CoV-2 waves in Europe. A two-stratum Sears model solution by Levin Japardies and Federico Lowe's in Medrevic's preprint October 23, 2020. We found that 100-day of mandatory isolations to healthy, which are under 60, for example, schools, workplaces closed, produces more final deaths in the vaccination if the vaccination date is later than December 28, 2020. So that comes from a study made in Madrid in February. Let me read that again. Produces more final deaths if the vaccination date is later than, for Madrid, February 23, 2020, Catalonia, December 28, 2020, Paris, January 14, 2021, London, January 22, 2021. We also modeled how average isolation levels change the probability of getting infected for a single individual that isolates differently than average. That led us to realize disease damages to third parties due to virus spreading can be calculated and to postulate that an individual has the right to avoid isolation during epidemics, SARS-CoV-2 or any other. Number 15. Did lockdown work? An economics cross-country comparison by Christian Bjornskov, SSRN working paper, August 2, 2020. The lockdowns in most Western countries have thrown the world into the most severe recession since World War II, and the most rapidly developing recessions ever seen in mature market economies. They have also caused an erosion of fundamental rights and the separation of powers in a large part of the world, as both democratic and autocratic regimes have misused their emergency powers and ignored constitutional limits to policy making. It is therefore important to evaluate whether and to which extent the lockdowns have worked, as officially intended to suppress the spread of the SARS-CoV-2 virus and prevent deaths associated with it. Comparing weekly mortality in 24 European countries, the findings in this paper suggest that more severe lockdown policies have not been associated with lower mortality. In other words, the lockdowns have not worked as intended. Number 16. Four stylized facts about COVID-19 by Andrew Atkinson, Karen Kopecki, and Tao Za. NBER Working Paper 27719, August 2020. One of the central policy questions regarding the COVID-19 pandemic is the question of which non-pharmaceutical interventions governments might use to influence the transmission of the disease. Our ability to identify empirically which NPIs have what impact on disease transmission depends on there being enough independent variations in both NPIs and disease transmissions across locations, as well as our having robust procedures for controlling for other observed and unobserved factors that might be influencing disease transmission. The facts that we document in this paper cast doubt on this premise. The existing literature has concluded that NPI policy and social distancing have been essential to reducing the spread of COVID-19 and the number of deaths due to this deadly pandemic. The stylized facts established in this paper challenge this conclusion. Number 17. How does Belarus have one of the lowest death rates in Europe? By Kata Karat, British Medical Journal, September 15, 2020. Belarus's beleaguered government remains unfazed by COVID-19. President Alexander Lukashenko, who has been in power since 1994, has flatly denied the seriousness of the pandemic, refusing to impose a lockdown, close schools, or cancel mass events like the Belarusian Football League or the Victory Day Parade. Yet the country's death rate is among the lowest in Europe, just over 700 in a population of 9.5 million, with over 73,000 confirmed cases. So let me throw in here a little editorial. So Belarus, which with 9.5 million population, stands around the same population as Sweden and Quebec. So we have Sweden and Belarus with about the same population that basically had almost no lockdowns and no sanitary measures. Has just over 700 in a population of 9.5 million, with 73,000 confirmed cases. And Quebec with similar population. You guys know the numbers about that? I'll leave that question open-ended. Number 18. Association between living with children and outcomes from COVID-19. An open, safely cohort study of 12 million adults in England. By Harriet Forbes, Caroline E. Morton, Seb Bacon, and all by MedRivix, November 2, 2020. Among 9,157,814 adults, over 65 years, living with children, living with children 0 to 11 years, was not associated with increased risks of recorded SARS-CoV-2 infection, COVID-19 related hospital or ICU admissions, but was associated with reduced risks of COVID-19 death. Living with children aged 12 to 18 years was associated with a small increased risk of recorded SARS-CoV-2 infection, but not associated with other COVID-19 outcomes. Living with children of any age was also associated with lower risks of dying from non-COVID-19 causes. Among 2,567,671 adults under the age of 65, there was no association between living with children and outcomes related to SARS-CoV-2. We observed no consistent changes in risk following school closures. Number 19. Exploring inter-country coronavirus mortality. By Trevor Nell, Ian Magorian, Nick Hudson, Pandata, July 7, 2020. For each country put forward as an example, usually in some pairwise comparison, and with an attendant single cause explanation, there are a host of countries that fail the expectation. We set out to model the disease with every expectation of failure. In choosing variables, it was obvious from the outset that there would be contradictory outcomes in the real world. But there were certain variables that appeared to be reliable markers, as they had surfaced in much of the media and preprint papers. These included age, comorbidity, prevalence, and the seemingly light population mortality rates in poorer countries than that in richer countries. Even the worst among developing nations, a clutch of countries in equatorial Latin America, have seen lighter overall population mortality than the developed world. Our aim, therefore, was not to develop the final answer, rather to seek common cause variables that would go some way to providing an explanation and stimulating discussion. There are some very obvious outliers in this theory, not the least of these being Japan. We test and find wanting the population notions that lockdowns with their attendant social distancing and various other NPIs confer protection. Number 20. COVID-19 mortality, a matter of vulnerability among nations facing limited margins of adaptation, by Quentin Delaroche-Lambert, Andy Mark, Julien Antero, Eric Glebour, and Jean-François Toussaint. Frontiers in Public Health, November 19, 2020. Higher COVID death rates are observed in the 25-60 degrees latitude and in the minus 35, minus 125 longitude ranges. The national criteria most associated with death rate are life expectancy and its slowdown, public health context, metabolic and non-communicable diseases, burden versus infectious disease prevalence, economy, growth national product, financial support, and environment, temperature, ultraviolet index, stringency of the measures set out to fight pandemia, including lockdown, did not appear to be linked with the death rate. Countries that already experienced a stagnation of regression of life expectancy with high income and NCD rates had the highest price to pay. The burden was not alleviated by more stringent public decisions. Inherent factors have predetermined the COVID-19 mortality. Understanding them may improve prevention strategies by increasing population resilience through better physical fitness and immunity. 21. States with the fewest coronavirus restrictions by Adam McCain. Wallet Hub, October 6, 2020. This study assesses and ranks stringencies in the United States by states. The results are plotted against deaths per capita and unemployment. The graphics reveal no relationship in stringency level as it relates to the death rates, but finds a clear relationship between stringency and unemployment. Interesting, Dom. Number 22. The Mystery of Taiwan. Commentary on the Lancet study of Taiwan and New Zealand by Amelia Janaxi, American Institute for Economic Research. November 2nd, 2020. The Taiwanese case reveals something extraordinary about pandemic response. As much as public health authorities imagine that the trajectory of a new virus can be influenced or even controlled by policies and responses, the current and past experiences of coronavirus illustrate a different point. The severity of a new virus might have far more to do with endogenous factors within a population rather than the political response. According to the lockdown narrative, Taiwan did almost everything wrong, but generated what might in fact be the best result in terms of public health of any country in the world. Number 23. Predicting the trajectory of any COVID-19 epidemic from the best straight line by Michael Levitt, Andrea Skyowicz, Francesco Zonta, and Medrevix, preprint June 30th, 2020. Comparison of locations with over 50 deaths shows all outbreaks have a common feature. H, defined as log, decreases nearly linearly on a log scale, where X is the total number of cases or deaths on day T. The downward slopes vary by about a factor of 3 with time constants of between 1 and 3 weeks. This suggests it may be possible to predict when an outbreak will end. It is possible to go beyond this and perform early prediction of the outcome in terms of eventual plateau number of total confirmed cases or deaths. We test this hypothesis by showing that the trajectory of cases or deaths in any outbreak can be converted into a straight line. Specifically, y equals 1n is a straight line for the correct plateau value n, which is determined by a new method, best line fitting, BLF. BLF involves a straight line facilitation extrapolation needed for prediction and is blindly fast and amenable to optimization. We find that in some lockdowns that entire trajectory can be predicted early, whereas others take longer to follow this simple functional form. To be very honest with you, this summary of this study, number 23, predicting the trajectory of any COVID-19 epidemic from the best straight line, was never that good in math, so I'm really confused by this summary. Maybe I would have to read the full study to understand it better, but I really had a hard time understanding that summary. Just wanted to be honest with you. Number 24. Government mandated lockdowns do not reduce COVID-19 deaths. Implications for evaluating the stringent New Zealand response by John Gibson, New Zealand Economic Papers, August 25th, 2020. The New Zealand policy response to coronavirus was the most stringent in the world during the level 4 lockdown. Up to $10 billion of output, more or less 3.3% of the GDP, was lost in moving to level 4 rather than staying at level 2, according to Treasury calculations. For lockdowns to be optimal requires large health benefits to offset these output loss. Forecast deaths from epidemiological models are not valid counterfactuals due to poor identification. Instead, I use empirical data based on variation amongst United States counties, over 1/5 of which just had social distancing rather than lockdown. Political drivers of lockdown provide identification. Lockdowns do not reduce COVID-19 deaths. This pattern is visible on each date that key lockdown decisions were made in New Zealand. The apparent ineffectiveness of lockdowns suggests that New Zealand suffered large economic costs for a little benefit in terms of lives saved. So, guys, this was a summary of studies made in the last 9 months suggesting that lockdowns do not work. Once again, this is not my opinion. These are studies made in scientific journals. They deserve to be taken into account in public policy of lockdowns. So once again, thanks for listening. See you soon.